Okay, so here, this shows again the latent gadolinium enhancement for infarcted tissue, right? And the interesting thing about this case or this example was that, or is that they can demonstrate in this patient how this changes over time. Like as the infarct sort of consolidates and fibroses over after the original insult and injury, you get this, large volume of much thinner myocardium, which is also kind of stiff, and it's essentially a scar, right? And that shows up like this remarkably bright signal after gadolinium enhancement. And for some reason, the cells that make up this scar retain the gadolinium contrast agent much longer than the normal tissues.
Mhm.
So it doesn't flow out. What we did here, did I show this? This is when you measure where an infarct is. So we have, in this 3D, right, with this patient with MR, we've got essentially a picture of where the infarct is in the three-dimensional structure of the myocardium. And then this simulation is an electrical simulation in which you pace the heart from the apex here. So we're going to give one pacing pulse. The color here represents the wavefront of depolarization through the tissue, right, from the pacing site. So the tissue up here hasn't depolarized yet. This is the wavefront of the depolarization moving through the tissue. So as it moves towards the base of the heart, you can see that the wavefront gets distorted by the fact that there is an infarct here, and it's mixed. It's a mixed infarct with normal tissue. So it's not completely transmural, or there are some elements of normal tissue allowing the transit of a depolarization signal through this space. But as you can see, it's completely slowed down, right? So you can see it hit it, slow down, and then it's very slow to emerge out of the infarcted area.
Yeah, it's kind of the same shape on the tail end.
Exactly. So it's delayed, right? It's delayed coming out here. And then the next pulse comes because we're pulsing at a specific rate, right? And this is all done in silico, like by Natalia Troyanova's lab, where she can simulate these depolarization fields in myocardium, and both in the ventricle and the atria. And so then the next pacing spike comes along and depolarizes again. And this is the first one, this is the second one. And you set up a spike train, right? So
did she make some kind of material model with the patient images?
Absolutely. You have both a geometric model where you know the size and thickness of the myocardium, and you have the composition with the gadolinium DTPA image where you know how much of this stuff is essentially fibrosis and how much is normal tissue.
Okay, just sort of going down that rabbit hole, do you think she used like patient-specific like material properties, or was she using like a general property of fibrotic tissue?
General.
Probably general.
Yeah. General. And also there are many parameters that go into determining this wavefront, and they're all sort of calcium signaling and things like that down at the cellular level. And then, there's a big model of how all those cells couple with each other to produce this wavefront. It's not a terribly simple model, right? But it's very well studied and well known. And so you can pulse the tissue at a specific rate like that, right? And now we'll pulse it faster. See how the waves got closer together?
Yeah.
And now we turn the pulsing off, and the heart just keeps going, right?
Oh, that's interesting.
Yeah, that's a self-sustained circular arrhythmia, right? So it's like a cat chasing its tail. The line of depolarization comes out, and by the time it comes up here, this is repolarized. It goes back in and then comes back out and goes back in. And so you can see it it go into, see it. So here we're pacing at a specific rate, and it's just the right frequency to cause that to happen, right?
Huh.
And so now you've got essentially a self-sustained arrhythmic excitation of the ventricle. The contraction of the ventricle is not going to go well, right? And this could degenerate into fibrillation, which is just a random set of depolarizations just walking around, right? So one of the ways of treating this abnormality, if somebody keeps generating these ectopic beats and then they go into, say, VTAC, and they have to be shocked out of it with their even a defibrillator, or they have to come to the hospital, get shocked out of it. You can go in here and try and kill, just finish them off, these cells that are half there, and just make it a blank slate so that there's no depolarization going through them. And then, it looks something like this, right? So now it just goes around it, right? It doesn't go through and come out late. It goes around it, and it deforms the waveform, obviously. But with those same induction pacing frequencies, whereas previously we could induce a ventricular arrhythmia, now you cannot induce it, right? So you say, okay.
It's interesting how how making it a total block rather than a slow is the solution.
Exactly. You just turn it into that so that it's just finish it off so that it's completely blocked. And so it just, you have to be careful, obviously, because if you could make ancillary burns and things like that would exacerbate the problem. So you want to make sure that you have your burns in the right spot, right? To try and clean this up and ideally probably make it an ellipsoid of dead tissue, right? So that this stuff can go around it without going through it. So that was the theory of that intervention, or using, MR late gadolinium enhancement for that intervention. And that's one of the reasons why we went to try and produce images not like this, but remember the images that were crazy high resolution. These, I think they're back here. Oh, maybe they're not. Sorry. The super high resolution images of an infarct is what we were trying to produce, and we just couldn't do it, like, because the tissue just didn't come back to the same place from beat to beat. So we gave up. So one day somebody will figure out how to do it. So the next application for intervention, and this is of interest to you, obviously, is modifying an interventional device. And this thing is a injection catheter. So you put this down a vessel, and then you use this needle to inject something at a target. So you could inject a very high concentration of, say, a chemotherapeutic agent if you're trying to kill a tumor, or you could inject something, to essentially ablate tissue in the myocardium. And one of the favorite things to inject back in the day, what was it? It was a toxic fluid, and I forget what it was that they used to inject to make lesions in the heart. But what we were doing with this was we were injecting stem cells. So we would grow up stem cells and load them up into this syringe in a suspension, and then inject those stem cells into the myocardium, right? And the idea was, because stem cells were proving very useful in orthopedics and stuff like that, that we would take these stem cell myocytes, or they would turn into myocytes, basically. That was the idea. And so we needed to get them to the right spot. So ideally, we created a coil that went along the shaft of the catheter, right? And then we took the signal from that coil, put it into its own receiver, and then that image we would in real time display on top of a real-time MR image during the same procedure. And so this is real-time images coming out at about 7 frames a second or something, with real-time images of the catheter on top of it, right? So you can see the artifact of the catheter there, but also this signal is what the backbone of the catheter, which is this wire that is essentially functioning as a receiver coil. And so what we were doing here is we were injecting a test bolus of gadolinium. So if you look at, hang on, let me bring it back here. So the catheter is now engaged. And just to make sure it is engaged, we inject a little test bolus of gadolinium contrast, and we can see, okay, we're in the myocardium, catheter's there. Now we can inject our stem cells, and we know exactly where they're going to go. And so, and you can look at it from different angles. You can change the angles in real time, et cetera, to see where the tip of the catheter is. And there's where the injectate goes. Not a simple problem, actually. Like when you kind of take it for granted, or you don't even think about it, like when you get a inoculation in a muscle, or penicillin or something in a muscle, and they just go boop and stick it in the muscle. Ask yourself this question: where's that stuff go? You know. And so you can in real time see where that stuff goes, you know, by looking at this, right? And it forms a little pocket of material and then diffuses out from there. And so we start in this condition where we have basically a bright spot where the gadolinium DTPA is. And then when we load up we go back here, take this out, replace it with the stem cells. And in fact, the stem cells themselves were grown up in a medium that contained ferromagnetic particles, right? So the cells themselves ingested these particles, and they themselves now are ferromagnetic, the cells, right?
Nice.
And so basically they're going to crush the signal around them, right? And so what you can do is you inject the stem cells and you get this picture, right? And so this dark signal is precisely where those stem cells are after the injection, because they're all marked with these ferromagnetic particles. It's a pretty cool technology.
Yeah, that's awesome.
Yeah. So this was real-time image-guided interventions with MR in the heart, right? So hard to do because getting images at 7 frames a second or whatever is not easy from an MR scanner. So you need a special set of gradients and you need a lot of juice. You need all of your equipment to be non-ferromagnetic, obviously. So all your catheters, everything like that. And so we had to get a whole bunch of special equipment and everything like that. But the guy I worked with a lot at NIH doing this, Robert Letterman, is doing this to this day. He's pioneered a whole bunch of interventions that are under MR guidance. It's a really cool lab. So that's what I did at the NIH while I was there. And the other thing we did, this was with a cardiac surgeon, is so this is a porcine heart. We've come through the chest wall and we've put a trocar here into the apex of the heart. And this is basically a guide wire on the apex, and that we push into the ventricular chamber. The guide wire itself, you can see just as a reduction in signal, right? This object coming in here is actually an aortic valve. And it's one we made. It's like a TAVR valve, but it was homemade, right? Before TAVR was a thing. We made this valve and wrapped it around a balloon and then inflated this balloon that you'll see the inflation come up and push the valve against the aortic root. So here the balloon's getting inflated, here the valve's expanding. The heart stops actually ejecting blood. Here we turn on a saturation pulse to get rid of the baseline signal and just see the signal from the balloon, bring it back to see the signal from the heart. Here's the valve, and then I'll just brush it up a bit, and then you pull all that gear back and you're left with a valve there. And so this was sort of MR guided TAVR before people were doing TAVR. And the great thing about it is you can now look at all of the flow signal and stuff using MR flow. You can look at any soft tissue damage and things like that. The bad thing about it is you have to work at an MR scanner, right? And so it's really loud. So everybody had headphones on and mics, right? So when they're talking to each other, we got a special set of headphones and mics built, so all the physicians could talk to each other during the intervention. And just as before, everything has to be non-ferromagnetic. And so you need to design a whole bunch of new stuff. But this was pretty cool. I love this project. Example, I guess I put this in here as just a comparison. Like if you buy a 1.5T MR scanner, let's say it's $1.5 million, then this one's going to be about $2 million or something. It's going to be an extra chunk to get this higher magnetic field. And the question is, do you need it for cardiac? And here are the two types of images just directly compared, from one to the other in the same person. And yeah, the image quality is better over here in that there's less noise. See, there's sort of noise hash here. There's less of it over here. Here you can see perhaps better details slightly, but this is, to all intents and purposes, very good, like for most cardiac imaging, right? And in fact, the trend over the last, I would say 7 years, is to in fact drop this down to 0.5T, because then you can run pulse sequences that don't really run very well at 1.5 and 3T, that use a lot of RF pulsing, and you have to eliminate a lot of the RF pulsing at 1.5 and 3T because you're going to heat up the patient, whereas you can use it at 0.5. And so the signal to noise loss is less, right?
Yeah.
So you're going to lose signal to noise as you go down in field, but you can pulse a lot more down here at 0.5. I should have put up 0.5. I'm not sure if a slide exists like that.
I've actually seen a system like that.
Yeah. And they're becoming pretty popular, actually. It was first started, I think, at the NIH. They started doing lots of studies comparing them, but it's interesting that we've come back to 0.5, because there's a huge debate at the beginning of MRI as to what was the appropriate field strength, and everybody landed here because that was the biggest field anybody could make at that time, sort of in the late 80s, right? And it was predicted, there's great papers too, by really smart people predicting that over 40 megahertz, you would not be able to do MRI because the RF would get absorbed too quickly. So none of the RF would get into the patient. And it, theoretically shown that you couldn't do it over 40 megahertz. This is 64, this is 128, and they look just fine. So that's always like, should you believe theory? Well, look at the measurement. So there's, you can see a difference in the signals.
Do you think there's a future for MRI guided surgery?
Yes, absolutely. I invested a lot of my life into that. And you can see things under MRI guidance. You just can't under CT or X-ray, right? And so there's a lot of X-ray guided surgery. There's a lot of ultrasound guided surgery. But the frustration is that the images really stink, right? And then, you can't really see the soft tissue in the fluoroscopy or X-ray guided surgery. So under certain conditions, if you're putting in a device and it's easily made MR compatible, and it's really important to understand the soft tissue environment you're in, then MR should be available, right? The problem is the market isn't that big. So the manufacturers have put a lot of time and money into interventional MR. So I don't fault them, but just the medical, market itself is pretty hard to break into when you're saying, hey, you should do this with a much more expensive piece of machinery, and with a staff that is highly specialized, right?
Yeah, they have to like set up a whole new kind of room,
Right.
Should be complicated.
Very expensive proposition. You've probably seen these, which I'm just going to go to, I think I can go to YouTube, right? Let me, very dramatic music. But this shows a 3D vector field. Well, I guess it's 4D. It's 3D vectors in 4D, showing, the trajectory of particles with flow from 4D flow, and it looks really cool, right? I mean, it's a really sort of eye-opening technology in that you can start to see, especially in people who have congenital abnormalities in their heart, you can see very subtle differences in flow in different places, and then you can simulate the surgery, the repair surgery, and ask the questions like, would the flow be sufficient after this potential surgery? And so I think 4D flow is also something that isn't used much, but will be used a lot in the future.